This is episode 2 of Fridays at RP. I almost called it First Fridays at RP, seeing as that just has such a catchy ring to it. But this Friday, it's about 7:30 in the morning. We are just about to walk into the clinic, make the most important thing of the day, coffee, and then we are gonna get rolling. So stay tuned and enjoy. All right, let's get to it. So one of the really important things with running a practice and not just actually practicing medicine is communication between employees, physicians, other providers, all that type of stuff. So first thing I'm gonna do here today is I'm gonna make what we call our IV labels. Okay, so we got them all in nice folders. But basically we need to have a communication system between the doctor prescribing the specific intravenous micronutrient protocol, the person who is making the actual intravenous bag, the IV bag, which sometimes is the same ordering physician, and then also the staff who's going to be administering the IV. And so we want to make sure that there's no confusion in which bag is for which patient, which IV protocol are they getting, so that it can be documented appropriately, if there's any changes to that protocol, and then like what the drip rate is and things like that. So that way, you know, we don't have something like an NAD IV where a staff doesn't know that one has to be really slow, and if that is, you know, open fully, that could cause someone to feel really, really sick. And so, so that's important. So that's the first thing that we're gonna get going on here today is some IV labels for better communication between staff, which is crucial. All right, so for our only procedure for today is the stellate ganglion block. If you watched last week's episode of Fridays at RP, I don't know, Mark, if you can kind of link that here. But we did a stellate ganglion block, but the one that we did last week was more for unilateral vascular migraines, which, to touch base on that, the patient has only had one headache last week and no migraine, which is a huge, huge improvement from the frequency that she was having them before. And so that is obviously going to be beneficial for her moving forward. So today, our stellate ganglion block is going to be done for a patient who has some mild traumatic experiences throughout their childhood and teen years, and that has resulted in some generalized anxiety that plagues the patient every single day. And so this is actually our second stellate ganglion block on this patient. The first one was done about 2 weeks ago. Generally, what we found clinically is that when we do 2 stellate ganglion blocks in the period of about 7 to 14 days, depending on scheduling and the patient, things like that, we get a stronger synergistic effect, because that first stellate ganglion block is going to really reduce that sympathetic outflow. And then the second one has that additive effect, and we end up seeing longer term results with that. And so that's usually why we pair 2 of them together as opposed to just doing one. Now, one of the biggest things that I talk with my patients about who have a past history of traumatic experiences or things that they have not worked through in the past is it is absolutely crucial to work with a qualified therapist or counselor in order to actually address those underlying issues that are resulting in the expression of the sympathetic nervous system. So whether that's through triggers or things like that. And the reason for that is because the stellate ganglion block in and of itself is not a curative treatment. There are some patients where if we do serial stellate ganglion blocks over time, what we see is let's say their generalized anxiety goes from a 7 out of 10, and maybe after 6 to 9 months, they're kind of down to maybe a 5 out of 10 at baseline. However, I mean, that is a minor reduction, and sometimes it's not even clinically significant. The real magic with the stellate ganglion block and PTSD is that it allows patients the opportunity to address the hard stuff in their counseling sessions, in their therapy sessions, without having really large triggers. And so we always recommend and pair these stellate ganglion blocks with some form of counseling, and try to include things like cognitive behavioral therapy, or EMDR, or anything that actually tries to address this old traumatic experience and helps the patient to work through it. And so normally what would happen without the stellate ganglion block is, let's say an easy example to give is a vet who gets triggered with fireworks, or talking about a specific incident from when they were deployed that had to do with an IED. And so if that person goes back to talk about that experience, they get a huge outflowing of sympathetic nervous system activity, so adrenaline, cortisol, all this stuff just starts flowing, and it becomes difficult for the brain to disconnect, to say that's in the past. Now with the stellate ganglion block, what happens is that connection has been dampened. And so when they start to talk about it, or when they are triggered from that event, whether that's fireworks or the sound of a car accident or something, then we see a big reduction in that sympathetic outflow with that triggering event. And over time, that re-exposure with that dampened sympathetic nervous system helps to train the body that you're safe. You are safe. This is not happening again, and I don't have to dump out a whole bunch of adrenaline, cortisol, and other things to protect you and keep you alive. You are safe. And so that's where the true magic in the stellate ganglion block lies for PTSD, anxiety and trauma, things like that, is pairing these injections with the hard work of therapy, counseling, and that type of stuff. And so that is going to be our first procedure for the day. And so I'm going to, just like a lot of my procedures, I always review the anatomy, the technique, just anything. I'll look to see if there's new research articles available, but I'm always trying to stay on top of that aspect of this art and this medicine. Is how do we do this? Why do we do this? What complications can arise? How do we mitigate them? What do we do about that? And just really try to step my game up. So hope you're all having a great day so far. All right, so our stellate ganglion block is now finished. We had a really good response from the patient, which means that we achieved a successful block. So one of the things that we look for to confirm a successful block after a stellate ganglion block is what we call Horner syndrome, which is going to be eyelid drooping or ptosis. We're gonna have injection of the eye, so we're gonna have a bloodshot eye. And then sometimes the patients will feel warmth or heaviness on that side of the face, and they can sometimes also have that into the arm. And so that is our Horner syndrome. Then we also track the temperature on that side of the face. We look at the temperature before the procedure, and then we track it afterwards. And we're looking for anywhere between a 1.5 to 2 degrees Celsius increase in facial temperature. When we see all that, that confirms that we've had a successful stellate ganglion block, and the patient is cleared to go into post-op and be monitored before they head out. If the patient doesn't have that response, it means that my needle was not in the correct location, and so we just go back in and we pick a new spot, a new angle to approach the cervical sympathetic chain in order for us to achieve that block before the patient actually goes home. So every patient that we do a stellate ganglion block or hydrodissection on, we confirm that we have the right location before they go home. All right, everybody, talk to you. Here's what I'll say. I never know if it's gonna be a series until after we do the first one. And so, because some people, we do one injection and they're 80 to 90% better after 3 months and they don't need another one. Some people, we will do an injection and 3 months later they're 30% better, and so we need to do another one. And so it's I can't ever predict how many an individual will need. What I can generally say is that for nerve issues, like what we're working with for you, usually we're looking at kind of 2 to 3 that's spaced out over a kind of 6 to 9 month period. So usually the injections are not done like once a week or even once a month if we need to repeat them. Usually we don't repeat it earlier than 3 months, because again, it takes time for things to heal. So we give the body time for it to heal. But you notice results over that time frame. So it's not like you do the injection and then you have to wait 3 months to know if it worked. We'll know if it's working usually within the first 4 weeks. If you start seeing, mild improvement, so let's say your leg pain goes from at its worst to 7 or 8 out of 10, and after a month you're like, it's not really 7 or 8 out of 10 anymore. Maybe it's like a 5, 6 at its worst, and maybe that's not happening as frequently. Then we know we're on the right track. We track that over time to see how much you heal, and then we decide if we need to do another treatment, if we think the next treatment needs to be stronger, if the next treatment doesn't need to be as strong. It's all really based on kind of your response to that first procedure. No. So not different than what you've probably experienced in the world of the epidurals. Let's say we do your first procedure and you don't see any response. It means that we weren't correct in our hypothesis. The things that we thought were causing you pain are not what's causing you pain. And so then we evaluate it maybe from a different standpoint and try to then figure out, okay, it wasn't that, it wasn't this, so maybe it's this. And we kind of go down that pathway of trying to figure that out. In the past 2 years of treating patients, I've only had 3 patients that we've had to do that. So my non-responder rate is low, but it does happen. And again, we never know if you're a non-responder unless we do a procedure, right? But it's not, right. If we do it once and you get no response, I will not say to you again, okay, let's just repeat it because maybe the second time will work. No, if the first one didn't work, the second one's not going to work. So we just need to change our strategy, meaning treat different structures. It depends on what type of healing response you're having. If we do the procedure and after, well, I guess they're kind of around the same time. If we do the procedure and you are not seeing any results and it is 4 weeks out and we look back and say, okay, it's been 4 weeks, although some people are late responders. That does happen probably from, 10% of the time. People won't respond until 6 to 8 weeks. But if we're 4 weeks in, you're not having a response and you want to go ahead and try the epidural, then it will impact it a little bit. But again, if you're not responding at that point, chances are you're not going to respond, so it's not a big deal. If you are responding and things are getting better, then having an epidural during that time will impact your healing. But it sounds like, my guess is that if your leg pain and your arm pain and stuff are getting better, there's probably no need to get an epidural, correct? So basically I think what you're trying to ask is, hey, if this doesn't work, how long should I wait to get an epidural? And as soon as we determine that, hey, I don't think you're responding, you could go and get one. And that would probably be about 4 weeks afterwards. I'd want to at least see 4 weeks to see if you're a late bloomer for your response. Awesome. Sounds good, Jonathan. And if we're all good, I'll see you next Friday. All right, so finishing up our Fridays at RP, we ended up having an add-on patient to the schedule. This is a lady who's pregnant. She's about 32 weeks right now. She's having some of the normal pains that can happen with pregnancy, right? Carrying a lot of weight on the front. You might have some swelling. You've got some relaxed ligaments. All that type of stuff can cause some pain. And so the traditional things that she did for her pain, massage, baths, all that type of stuff wasn't working for her. And I've treated a few other things for her in the past with some headaches, and so she came back to see us. And so the big things that were bothering her was she was having some left-sided myofascial tightness kind of coming from under the armpit region that was wrapping around to the chest. And then a little bit further down, and it was a separate issue, but some pain that was wrapping kind of from the side of the belly that was then wrapping down kind of towards the belly button. And then also some anterior hip pain kind of right at that hip crease fold, kind of where, you know, the womb and the belly kind of stop before it actually goes to the leg. And so our physical exam was basically indicative of, you know, there's no major joint issues going on here. There's no new muscle tears. This is not a traumatic, you know, thing that happened for her to cause us to have to go down that rabbit hole. And so initially we're thinking, okay, let's do some dextrose, let's do some perineural injection therapy and some nerve hydrodissection. So what we ended up doing was we did some perineural injection therapy for the genitofemoral nerves on the anterior aspect of the hip. Those nerves can commonly be pinched in people who are constantly in a flexion position, so cyclists a lot of the time can have issues there, but also you know, women who are pregnant because of the belly and the womb kind of coming over and applying some compression where those genitofemoral nerves are coming out. So some simple perineural there, which is just 5% dextrose, which is safe in pregnancy, and our injections are far enough away from the womb and anything like that that we're not concerned about any risk there. Then for the this kind of chest tightness and the this pain that was kind of coming from the lateral side down towards the belly button. What was interesting about that pain is both of them followed a very dermatoma-like pattern, although this wasn't, I don't think, a true nerve root issue to cause some radiculitis, but rather some inflammation of the lateral cutaneous branch of the dorsal rami. And so from the back side, we have the dorsal rami, and then it gives off a medial branch. That medial branch goes and supplies the posterior aspect of the spine. And then the lateral cutaneous branch usually wraps around and then actually comes and meets with the anterior cutaneous branches on the front side. And so because it followed that pattern where it starts high and kind of goes low, which is following the ribs, we decided to do 3 different things. Erector spinae plane hydrodissection at the level of T4 and T10, because the T4 region is going to cover that kind of chest and breast area, and then the T10 region is going to kind of cover the abdominal region. And then also a serratus anterior plane hydrodissection. Now, those techniques, the erector spinae plane and the serratus anterior plane, those are interfascial hydrodissections. Now, traditionally, those are actually used as regional anesthetic blocks. So prior to surgery or after surgery, an anesthesiologist may go in and do those blocks with local anesthetics in order to block those the distribution. And so, for example, if someone is having abdominal surgery, sometimes they will do a erector spinae plane block at the level of T10 to provide basically analgesia or a reduction in pain. It's not usually not full anesthesia with these blocks, but analgesia of that area, so that way post-op patients are in less pain. And so we have been using this over the past few months with D5W in order to basically calm down those cutaneous nerves that are traveling through those interfascial planes. So we'll track her over the next week to see how she does, and that wraps up our Fridays at RP. Guess we'll see y'all next week.